This section will cover non-invasive positive pressure ventilation. The therapeutic goal is to provide non-invasive positive pressure support. NIVST increases airway pressure for alveolar recruitment, increases FiO2 concentration, increases flow to assist with work of breathing, and increases mean airway pressure to promote gas exchange. The patient's support is delivered through a non-vented mask covering both the mouth and nose, using the heated and humidified circuit. Non-invasive support is indicated for use in spontaneously breathing, hypoxic and/or hypercarbic patients with increased work of breathing or other signs of respiratory distress. Contraindicated in any patient with signs and symptoms of immediate respiratory failure, patients that are unable to follow commands, loss of respiratory drive, and pediatric patients under 5 years of age. Initializing non-invasive ventilation. Set up the Hamilton T1 H900 humidifier and heated circuit. Perform the preoperational check and select the appropriate mask best suited for patient comfort. From the main screen, select patient gender and height. Default settings for inspiratory pressure and PEEP are based off of ideal body weight. Select Start Ventilation and then apply the mask to the patient. The current slide shows the basic adjustable parameters for NIVST: rate, eye time, flow trigger, inspiratory pressure, PEEP, FiO2, and pressure limit are all currently displaying preset defaults. Any setting changes should be based upon patient response to therapy, trending vital signs, or ABG results if available. Clinical progression of the patient depends on the patient's response to the intervention. NIVST does have its limitations as the patient's condition worsens or the disease process unfolds. Non-invasive support may no longer be an option. The following are signs that the patient is failing NIVST and the provider must take action: decreasing LOC, physical exhaustion, worsening respiratory drive impairment, worsening hypoxia in the presence of 100% FiO2 or a PaO2 less than 60 millimeters of mercury, and increasing CO2 retention of 55 millimeters of mercury or greater. Any of the above conditions are signs that the patient requires immediate intervention and should prompt the provider to prepare for intubation and invasive management. Management guidelines. When adjusting the inspiratory pressure, the overall pressure the patient receives is the sum of the inspiratory pressure and the PEEP combined. An inspiratory pressure of 16 and a PEEP of 5 deliver a peak pressure of 21 to the patient. To improve end-tidal CO2 maintenance and ventilation, increase the inspiratory pressure by increments of 2. Do not adjust PEEP if the patient has an adequate SpO2 of greater than 92%. To improve oxygenation, first increase the FiO2 with a goal of less than 60%. Then increase the PEEP in increments of 2 and also the inspiratory pressure by the same value to maintain a delta P. With NIVST, small changes in eye time can also improve oxygen exchange. Prepare to provide adequate sedation and anxiolysis to promote patient-ventilator synchrony. Clinical tips. A good mask seal is key to successful care. If the patient is failing NIVST, leave the mask in place, increase FiO2 to 100% for nitrogen washout while preparing for intubation. Continue using the heated and humidified circuit to provide optimum patient care. Familiarize yourself with all circuit adjuncts to improve patient outcomes. This concludes this segment on non-invasive positive pressure ventilation.